So Kathy and Ashley. Maybe Jeanette. How is everybody today?
Doing well, thank you.
Good.
Good, good. Okay, I'll go ahead and get started. So today, welcome to week 8. We're going to cover content from week 7 and week 8. We'll cover a lot of that in the quiz rationales. And then we'll go through some additional material when we're done with the quiz. Okay, so the quiz will be first off. Don't start the quiz. I have a couple of housekeeping items to go through before we get started. And if you've tried to pull up the quiz prior to 1 o'clock, you'll have to refresh when we get to the quiz. So a couple of things. One is I sent an announcement earlier today with regarding HESI schedules. So I have access to a master list to see what campuses, if they've scheduled their HESI dates yet for community. And so I was able to send you a list. I know this class is limited to, I believe, Port St. Lucie and Essington, and both of those campuses had their dates scheduled on them. Let's see, Essington was Monday, the 16th of week 11. Port St. Lucie was Tuesday, the 17th. Okay, so find your campus. Now, I don't have anything to do with your scheduling. I'm simply trying to give you a heads up early on of when your HESIs are scheduled for on campus. You, as always, will need to sign up through your campus for your HESIs. Okay, I don't know if either campus has received notice yet. Have you received notice of HESI signing up for HESIs? No? Okay, that should be forthcoming probably in the next week. But I want to give you an idea of when at least when your community HESI was scheduled. Okay, so hopefully that's helpful. Okay, with regards to exam 2, I posted the grades over the weekend along with the communication that the homework grades have been turned off. Okay, so overall, very, very well done. Very well done on exam 2. Okay, congratulations. Really, really proud of you guys. I didn't have a lot of attendance at the exam 2 reviews, so my assumption is that you were watching the recordings. Is that correct? Yes, no? Just want to
Yes,
get a
I did.
feel.
Yes,
Just want to get a
most
feel
times
for.
when you're doing your reviews, we're in class.
Pardon me?
When you do your exam reviews, I'm in class. So the only
Okay.
way that I can do it is to watch the review.
Okay, okay. Are those reviews helpful?
Yes,
Okay.
yeah, I find it helpful.
Okay, fantastic. Well, overall, this is 2 classes combined into one. So a lot of students, but overall, well done. Well done. Way to go. If you score below a 78, I really would like for you to reach out to me to schedule a time, if you already haven't, to schedule a time to look at exam 2 and see what concepts you were struggling with. Okay? If you've scored above a 78 and still want to review any concepts that you struggle with, please let me know. I'm happy to meet with anybody. Okay? What else was I going to tell you guys? The HESI, exam 2. This upcoming weekend, I'll be sending you, it will be a pretty detailed announcement. In week 9, I'd like to send out a roadmap. Okay, that it will cover weeks 9, 10, 11, and 12 of everything that needs to be getting done because the next 4 weeks are super busy. Okay, I hope to be grading the group projects tonight or late this afternoon, this evening. And so you should see your grades for that in the next 12 hours or so. Okay, hang on, I'm just checking in. Few more students here. Okay. Does anybody have any questions about anything? Okay. So it's 1:05, so refresh your quiz. Okay. And we will be coming back in about 20 minutes to accommodate for accommodations. Okay, so that would be 1:25. Okay, so when you're finished your quiz, take your time with it. Please submit it before you go off camera, but everybody needs to be back on camera or available between 1:20 and 1:25. How does that sound? The access code, I'll put it in the chat, is my last name. Same as the other quizzes. Okay. So there you go. So I'm going to mute myself. And make sure everybody else is muted and get going on the quiz, and we'll see you in about 20 minutes. Sound good? And everybody, please stay on camera while you're taking the quiz. Fidel, I can't see you. Jade, I can't see you. Sienna, thank you. Jasmine, I can't see you. Hey, if everybody could start coming back on, it looks like everybody's done. All right. We'll just wait a sec for everybody to come back on camera and then we'll go through the quiz. How'd you do? Good? Have a question for you. Are you able to see the rationales?
No,
You're not able to see the rationales if you got the question correct or incorrect?
no, we can't see the questions.
No.
Okay. Have you been able to see the rationales? Have you been able to use those to go back and review them for the exams? Yes or no?
Yes, the last ones, but this one, it didn't come up.
Okay. So I need to figure out what's going on with my settings for this particular quiz. But the last ones you've been able to see the rationales as we go, but not
Yes.
this one.
Correct.
Pardon me?
She asking if we can see the quiz the last time, but we were able to see the quiz.
Yeah, I don't know what's going on with the settings. I had this issue with my Monday class yesterday. So you're going to have to follow along with me on my screen for the rationales, okay? And then once I get these settings adjusted, I thought I had it adjusted today. I haven't heard back from my Monday class that they haven't been able to get in. So I'll have a look at it, but follow along with me today, okay? And then I promise you'll be able to see the rationales here soon when I figure out what issue I'm having in my settings. I'm not sure what issue I'm having. Okay? Were you able to see the questions you got wrong?
No, it just says it's hidden.
You can't see nothing but the score.
Right.
Okay. All right. Let's see. All right, well, I'm not gonna try and sort that out right now because I don't want to waste any class time. All right, so just take notes on the rationales. All right, like I said, I thought I had resolved this. What I did with my Monday class, I did with the rest of my section. So anyway, I apologize for that, but you'll be able to see the rationales now that we're going through it. Okay, so I'm going to share my screen. Is everybody back? Jade, do you want to turn your camera on, please? Alan, Chanel, if you could turn your cameras on. Okay. I'm gonna go ahead and share my screen. We'll go through the quiz. Can everybody see my screen? Yes? No?
Yes, yes.
Okay, thanks. All right. A lot of the questions in the beginning were about infectious disease and or infection control. So let's go through that. And as you can see, I have the rationales in here. I don't, unfortunately, you can't see them, but you will be able to, but follow along with me. Okay, so first question is, which of the following are effective parts of infection control to reduce the incidence of healthcare associated infections, HAIs? Okay, my Monday class confirmed that you have already gone through a lot of this infection control material, right, in your previous classes. Foundations? True? Good. So hopefully this will be just a review for you. Okay, so infection control measures to reduce the incidence. Proper use of PPE, hand hygiene, and the environmental infection control measures, whatever work setting or work site you're working in, they will have infection control guidelines. Okay? We don't need to explain procedures before starting. So let's look at the rationale here. Okay, so healthcare associated infections are infections that patients get while or shortly after receiving healthcare, right? To prevent HAIs, we can use a variety of procedures, okay, including hand hygiene.
Professor, I'm sorry to interrupt you, but Steffi said that she had to restart her laptop. So I'm sorry to interrupt your class for that, but she told me to let you know.
Okay, thank you.
You're welcome.
Okay, so good hand hygiene. All staff and patients should wash their hands frequently and correctly. Personal protective equipment, whether it's gloves, mask, gowns, goggles, face shields, or a combination of all. Okay, aseptic technique, right? Following the standards of sterile techniques when performing surgery, caring for wounds, inserting catheters for medical devices. And then environmental infection control, right? We want to keep the healthcare environment and equipment clean and disinfect surfaces and floors regularly. Okay, so that's a good summary of prevention strategies for reducing acquiring health care associated infections. Okay, any questions about that question? Oops. In addition to observing standard precautions for a client with primary TB, Lisa the nurse should also observe which of the following. Hopefully everybody got airborne precautions, right? With active TB, right? The rationale states, the rationale gives you examples of transmission-based precautions. Okay, so airborne is the second one. Airborne precautions we used for measles, varicella, TB. We also use standard precautions for all patients. There's also droplet precautions, meningitis, pneumonia, diphtheria. And there's also contact precautions. We use for GI, skin, wound infections, RSV, herpes. Okay, so this rationale is a good summary of the different kinds of precautions we would use that are transmission based. Okay. Number 3, airborne precautions require which of the following precautions? Okay, we know that N95, private room, and the patient should leave the room only for essential activities. We don't want the patient wandering all around, right? And so the next rationale is a summary about airborne precautions in general. Right? So according to the CDC, airborne precautions prevent transmission of infectious agents that remain infectious over long distances when suspended in the air, right? We use airborne precautions in addition to standard precautions for patients with known or suspected serious illnesses transmitted by airborne droplet nuclei. Okay? The preferred placement for these kinds of patients is in an airborne infection isolation room that's equipped with special air handling and ventilation capacity. right? An N95 in particular, an N95 particulate filter respirator is also warm, right? And the patient should only leave the room for essential activities. Some examples we talked about in the last rationale, but measles, chickenpox, pulmonary TB, SARS. Okay.
Professor Morel,
Pardon me?
I have a question for you.
Sure.
We just went over this in our pediatric class, and I was looking at my book. It says the respirator mask are removed from exiting the room.
That the N95 mask, what?
No, it's not the N95. It's the respirator mask are
Okay.
removed when exiting the room. I get a little confused regarding this one. It's in chapter 32
Chapter
And the
32 in
maternal-
our class or in the pediatric class?
in the pediatric class.
Okay, I'm not familiar with chapter 2 in
Um,
the pediatric book.
Does it say respirator? Because a
Yeah, it's-
respirator and an N95 are different. The respirator could be for people that space is too small for the N95. Because that's what I
But-
have to use at work because I can't use the N95 because my face is too small. So
But
that's-
yeah. So in that case, if the respirator is removed, we need to put a N95 for that patient.
Correct.
Thank you.
Okay, let's see. The next question is about medical asepsis principles. So which of the following medical asepsis principles are sufficient for care in the home? Okay, contact precautions. All right, select all that apply. So when you're using contact precautions in the home, what should you be doing? You should have gloves on. You should be disposing of soil contents in a securely tied plastic bag and using frequent hand hygiene. Okay, there's no need to change our clothes often, especially if we're following the other precautions. So this rationale is a good summary of what contact precautions are. All right, so contact precautions are a set of safeguards used by healthcare personnel to prevent the transmission of infectious agents that are transmitted by direct or indirect contact with the healthcare environment. All right, and contact precautions are used in addition to standard precautions, because we talked about way back up here with standard precautions that standard precautions are used on all patients at all times, right? So contact precautions is in addition to that. Okay, so some examples of illnesses that may require additional in addition to standard precautions may require contact precautions, stool incontinence, draining wounds, secretions, pressure ulcers, maybe a generalized rash, ostomy tubes, ostomy draining, or the drainage from ostomy bags, right? Infections with organisms transmitted fecal orally, maybe C. diff, wound and skin infections, maybe MRSA. Those all are going to require an additional precaution of contact precautions in addition to standard precautions. Okay. Okay, this next question is about HIV. All right. Sarah the nurse knows that a client needs to understand that an HIV test cannot identify infections that may have been acquired within the previous 3 months before the test. Which of the following statements by the client indicates further teaching is needed? So what are we looking for here? What kind of question is this? This is a negatively framed question, right? You're looking for something that the client says that needs more, further teaching is needed, or clarification is needed, or correction is needed, right? A is absolutely correct. Appearance of the HIV antibody can take up to 12 weeks. Thus, the test could be negative now, but positive in 12 weeks. All right, the test could be negative early in the testing, and the client might still have the HIV infection. That's also correct. Right? And D is correct. All persons who have an STD test should be counseled about risk reduction activities before and after the test is done. Okay, so C, the correct answer, if the client says risk reduction if the nurse says risk reduction counseling is not indicated for up to 12 weeks, the test results would be valid. That's not true. A is actually the rationale. The client needs to understand that the HIV test cannot identify infections that may have been acquired within the previous 3 months before the test. Appearance of HIV antibodies can take up to 12 weeks, right? The test could be negative now, but positive in 3 months. And this next paragraph in the rationale is an excellent summary of HIV, how it's spread. Okay, what is HIV? Bloodborne infection spread through sexual contact, sharing of needles, and it can also be spread vertically through breast milk during pregnancy. Okay, it used to be spread through blood transfusions. Okay, but now blood is now tested for the HIV infection. After needle stick injuries or high risk exposures, post-exposure prophylaxis is very effective in preventing HIV. Okay, the other sexually transmitted diseases are at high risk for HIV due to the traumatized tissue. Right, so clients that may have chlamydia, syphilis, herpes, gonorrhea, they're at high risk due to the traumatized tissue of developing HIV. Right? We know that open lesions and inflamed tissue increase the risk of HIV. And again, HIV testing is antibody testing, cause false negatives for up to 3 months. Okay, testing should be repeated. Any questions on that? That rationale is a good summary of the HIV. Okay? This next couple of questions are about disasters. Okay, natural disasters can be devastating to the community. The nurse is providing a yearly education class in the community. Which statement by one of the community members indicates that further teaching is required? Again, another negatively framed question. So you're looking for somebody that says something that either needs to be clarified or needs further instruction. Okay. Well, we know water can be rendered safe for drinking by boiling. Water can be rendered safe for drinking by treating with household bleach, and I'll go through the specifics and the rationale. We know that water can be rendered safe for drinking by removing it from hot water heaters or commode tanks. So a combination of all of those three renders water safe to drink. I'll cover that in the rationale. However, C is incorrect. Water cannot be rendered safe for drinking by allowing water to sit for 24 hours and then pouring it through layers of cotton towels. That's just not correct. Okay?
Professor Melville,
Yes, Darlene.
regarding the water you're taking from the water heater, should it be boiled after, or should I put the home Clorox in it, or
Well,
it's just
Well, the contaminated water needs to be emptied. And here's the rationale for when water can be rendered safe to drink or put back in the commode. Okay? Boiling 3 to 5 minutes. Treating with household bleach, 1 ml, 16 drops per gallon, letting stand for 30 minutes. And removing the water from hot water heaters and commode tanks. Right, allowing the water to sit for 24 hours or pouring water through layers of cotton does not adequately render the water safe to drink. So it relies on 3 things: the boiling, the bleach, and removing the water from hot water heaters and commode tanks. Does that answer your question, Darlene?
Yes, thank you.
You're welcome. Okay, this is about bioterrorism. Okay, the lesions of what can be found on the palms of the hands and the soles of the feet? Did everybody check B, smallpox? What's the difference between smallpox and chickenpox?
Smallpox only occurs on the hands and soles of feet.
And correct, Caleb, this does not happen with chickenpox. Right? Lesions are not found in those 2 areas with chickenpox. Okay? So smallpox, this rationale explains what smallpox is. All right, it may start with flu-like symptoms, then develops into a rash with red spots. Those red spots then become deep pustules and leave craters. That doesn't happen with chickenpox. Okay, chickenpox starts with a rash, smaller red dots, and they turn into blisters. Okay, they're not deep pustules or leaving craters. Lesions of smallpox can be found on the palms of the hands, of the soles, and the soles of the feet. The lesions of chickenpox do not appear there. Okay, so that's a very distinct difference between chickenpox and smallpox. This is another bioterrorism question. Which actions by the nurse accurately indicates understanding of proper management for a client that's been exposed to a toxic chemical spill? Select all that apply. All 4 answers are correct. Okay. In managing a client that's had a exposed to something toxic. Clothing and contact lenses are considered contaminated and should be removed and discarded. We use tongs to prevent touching of any kind of clothing. Eyes should be irrigated for 10 to 15 minutes. And clothing should be placed in a plastic bag for disposal. Those are the 4 guidelines. Okay. And these questions all came from your readings in your chapters. And that I'm not going to go through the rationale because it just repeats what the 4 answers are. This next question is a home health question, which is a concept from week 8. So the sharing of information from one healthcare setting or provider to another is critical for community-based care, especially when the clients are making the transition between hospital and home. Which of the following is an example? Did everybody get C on this? Yes? Okay, good. Because in the question, it says they're transitioning between hospital and home. So obviously the answer C, communication between acute care, which is the hospital, and the home health agency staff, which is going to be where the staff comes from to care for the client. Okay, it has nothing to do with emergency room staff, has nothing to do with a post-surgery staff, has nothing to do with the pharmacy. All right, the question is asking transition between hospital and home. Okay, so let's look at this rationale for home health. Interdisciplinary collaboration is required in the home health setting. right? Interdisciplinary collaboration does not conflict with the concept of providing direct care services. You want that collaboration between the direct care services providers and the home health agency. The sharing of information from one healthcare setting or provider to another is critical for community-based care, especially when the client's making the transition. Why do you think that is? Why is this interdisciplinary communication so important? What did you learn from your readings about home health? Why is it so important? Anyone? Anybody have any idea why this interdisciplinary communication is important? I have a lot of students in this class.
So-
Somebody should be able to answer this.
It's so that they are meeting the same goals, because if the therapist said they recommend for them to get up and walk about, it's nice for the nurse to know when she goes for her visit to be like, okay, Ms. Johnson, have you been walking around? So it coincide with their plan to communicate together. So that's why it's important.
That's exactly right. Thank you, Tamisha. Right? What if the client transitioning from hospital to home needs PT services? What if they need aid services? What if they need wound nurses? What if they need medical equipment, oxygen? That interdisciplinary communication is key, is the patient has to be all prepared when they're home, when they get home, right?
Correct.
And the last question, physical neglect. So physical neglect refers to the failure of the parent, the guardian, the custodian to provide adequate food, clothing, shelter, hygiene. And the correct answer is, in addition to that, necessary medical care. Okay, physical neglect, I'm reading the rationale. Physical neglect occurs when a parent, guardian, or custodian fails to provide for the child's basic needs. The basic needs are food, clothing, shelter, education, medical care, or supervision and abandonment. Does anybody have any questions about any of the quiz questions? Okay, can everybody see my screen? Let me
Yes.
check. I've got 4 messages in the chat. Let me. Okay. Okay. I'm bringing up my notes because there's a lot to cover. Okay. You have the PowerPoints to support weeks 7 and 8. You also have the concept recordings for weeks 7 and 8. So please review these, but I'm bringing up my notes because there's a lot to cover and I want to make sure I cover it all. Okay. So week 7, we covered infectious disease prevention and control. We covered that pretty good in the quiz rationales and the quiz questions. HIV, TB, STDs, bioterrorism, and disaster. Okay, so let's review what we didn't cover. Okay, so with regards to infectious disease prevention and control, all right, when we talk about the environment, okay, any environment, we're referring to the physical environment, the biologic environment, social and cultural factors, right, that are external to the human host. The host is us. What's going on in our environment? Okay. Environmental factors do facilitate the transmission of infectious agents from hosts, which is us, to other people. So think of the flu. Okay, let's say we're working in close contact, we have the flu, but we're still working in close contact with others. Right? That environment is prime for the transmission from one person to the other. Okay? When we talk about transmission, we talk about the epidemiological triangle. Okay, and I'm right here in my notes. Okay, the epidemiological triangle refers to infectious disease transmissions. Okay, you have to have all three. That's why it's called a triangle. You have to have an agent, a host, and an environment. What is the agent in the environmental epidemiological triangle? What's the agent?
The flu, cold,
Whatever, yes, the flu, it could be viral, bacterial, chemical,
Whatever communicable disease.
whatever the agent is, right? Is it a bacteria? Is it a virus? Is it a chemical exposure? Okay, so you have to have an agent. COVID, influenza, anthrax exposure. What else? Pneumonia. You have to have an agent. Okay, that agent then infects the host. The host is us. Okay, what kinds of things affect the host? How healthy we are or how unhealthy we are. Is the host immunocompromised? What is the age of the host? What's the ethnicity? What's the gender? Okay, some agents, some of those details make a difference. So we have to have an agent that infects a host, right? And then the environment is the third part of the triangle. What's the environment? Is it a group of people that are living in close quarters, like, let's say, the migrants? Remember the migrants working on the farm, living in close quarters? Is it a nursing home, assisted living facility? Is it a school with, for the most part, healthy kids? What's the environment? Because that makes a difference as well. So let's take COVID, for example. COVID is your agent. Okay. The host, let's do two scenarios. One is a long-term care facility full of elderly clients. And the other is a elementary school, for the most part, healthy kids with not a lot of comorbidities. Or the nursing home with the elderly patients. They're elderly. They may have other chronic diseases or comorbidities going on. All right, so those are the two different environments. Do you see how there may be a difference in who gets sick and how sick they get? Okay, this long-term care facility with elderly comorbidities, they may not be very healthy or have other things going on. They're much more at risk from being affected by the agent COVID. And we saw this play out during the pandemic. The elderly and the immunocompromised, the sick clients got more sick, did they not? Whereas the kids in the schools, not so much. They didn't have the comorbidities. They were healthy. Okay, take influenza for another example. Let's say the people that got the flu shots, okay, especially the elderly, maybe they were less at risk to get severely sick from the proper influenza, right? So my point is, all these three are present in determining how sick people get, how it's transmitted. Okay, you have to have an agent that infects a host, and then whatever the current environment is will affect the outcome. Does that make sense? That's the easiest way I can explain it. And you will get, this will be on exam 3. So I want you to make sure you understand it. There's a numerous scenarios that can play out. Is the agent a serious agent? Is it potential anthrax exposure? Is it the flu? Is it some kind of virus? Who's your population that's getting infected? Healthy, not healthy? Environment. Risk factors in the environment healthy environment. There's many different ways this can play out. But my point is all three have to be present with regards to the transmission of a specific infectious agent. Okay, does anybody have any questions? Couple of other things about infectious disease prevention and control. Incubation period. What is it? It's the time between the exposure and the first appearance. So they get chickenpox. I do this in the schools all the time, or did. You know, in our preschools, let's say that chickenpox became an issue. Incubation period is that time when the kids were exposed to when they start to show symptoms, right? There's a couple of definitions to be familiar with. Epidemic and endemic. Okay, epidemic means that the occurrence is clearly in excess of what the expected levels are. So that happened with COVID. That's why COVID became an epidemic. There were so many cases. Okay, in some seasons we have epidemics of flu, where the proper flu cases are much higher than expected. Okay. And then we have endemic. Endemic means it's always going to be there. Okay. So endemic would be the flu. A flu would be an example of endemic. The flu is always going to be here. There's no cure for it. Same with COVID. COVID now has moved into the endemic level. It's always going to be here. Okay. We covered healthy water. We covered proper hygiene. We covered contact precautions. The last thing I wanted to mention about infectious disease prevention and control is requirements of reporting. I don't need you to know every specific infectious disease that needs to be reported. What I need you to know is that there are federal laws requiring the reporting of certain diseases. I had to do this in the schools all the time, pediatric offices, doctor's offices, emergency rooms, urgent cares. There's mandatory reporting required for certain diseases. Okay, that's federal law. There's a list, a local, state, federal list of reportable, communicable infectious diseases. Okay, that get reported locally, then they go to the state health department. The state health department reports to the CDC. And that's all part of surveillance of outbreaks, right? So when I had a kid with, if I had a kid with pertussis in the schools in a particular classroom, pertussis is reportable to the local health department, the state health department. So I would have to report that so they could monitor if other kids may not have been immunized against pertussis or how many cases of pertussis there were. Okay. If you're working community nursing, one of the things you'll be participating in with regards to infectious diseases and communicable diseases is surveillance. Okay. So observation, surveillance. We're collecting data. So let's take the pertussis. I'm collecting data on kids that have been diagnosed with pertussis, kids that may be symptomatic in a particular classroom, kids that are asymptomatic and have no issues. It's observation and surveillance. So collection of data, analyzing it, interpreting it, and providing information to monitor the trends. Okay. What are the patterns of occurrence? Patterns of occurrence for infectious diseases come in several different ways, and I've highlighted them here. You could have a point source outbreak, an intermittent outbreak, a mixed outbreak, and a propagated outbreak. Okay, point source is there's a central point, central There's a central event. Okay, all people are exposed to the source, resulting in everybody getting ill. So best example is maybe a release of a gas in an enclosed place, like a train or a plane. Okay, everybody's exposed at the same time, everybody will get ill. Intermittent, right? You may be exposed over a period of time. People getting sick at different times. This is common, intermittent outbreak is common when we're talking about food poisoning. Let's say a restaurant is serving a batch of lettuce over 4 days. Okay, and the batch is bad. People over 4 days will be getting exposed, so they may be getting sick at different times. That's intermittent. Mixed outbreak is one person passing it on to the next person. Okay, mixed. So that's like the flu, passing on the flu. Okay. And then the propagated outbreaks, there's really no common source. Okay, they spread gradually from person to person over long periods of time. And a good example of that is tuberculosis. Okay. Vaccines, when it comes to infectious and communicable diseases. Vaccines are one of the most effective methods of preventing and controlling communicable diseases. I had lots of vaccine conversations with parents. Okay, there are parents that choose not to have their kids vaccinated, and that's fine. Okay, it is a federal law that all kids be vaccinated before they enter school. However, each state sets up what they want for exemptions, so parents can opt out. Okay, personal exemptions. I don't want my kids to get vaccinated. Medical exemptions from a physician. Maybe the kid has a diagnosis and vaccines are not recommended. And then there's religious exemptions, right? Our religion does not support vaccinations. Okay. The only thing we can do with parents is educate. Educate on how vaccines are effective methods for preventing communicable diseases, and also come up with a plan. All right, if the child's not vaccinated, what if the child's in a classroom, they don't have the pertussis vaccine, and a kid comes down with pertussis? What's the plan? That's what needs to be discussed with the parent. We used to recommend that if you weren't vaccinated for a particular particular diagnosis and it came up in your child's classroom or daycare or after school program, we used to recommend to keep the unvaccinated child home until it was resolved, because they become very high risk for developing whatever that infectious communicable disease is that they're not vaccinated against, right? Talk about HIV infection, hepatitis, TB, and STDs. Right, we know that STDs are major public health care challenge in the United States. Okay, some of the bacterial STDs, gonorrhea, syphilis, chlamydia. These can be treated with antibiotics. Other STDs are viral. Viral can't be treated with antibiotics, correct? They be treated with antivirals, but not antibiotics, right? Those become symptom management, right? One of the STDs to mention is syphilis. Okay, syphilis is a particular STD that can be transmitted transplacentally from mother to fetus. If untreated, has the potential of creating significant harm to the newborn. I've listed out here chlamydia and gonorrhea, syphilis, and herpes. I would like for you to have a look at those in your reading. Are they bacterial? Are they viral? Can they be treated? And what's some important information to know? You probably already reviewed this in your med-surg classes, right? Have you reviewed STDs in your other classes?
Yes.
Okay.
Yes, ma'am, we have.
Okay, and all this information in front of you is in your readings. All right, so there are questions about STDs on exam 3. What I would encourage you to know is bacterial or viral, how are they treated? What's some teaching points with clients that have these STDs? With regards to sexual contact, with regards to communication of previous sex partners. Symptomatic, asymptomatic. Okay. Hepatitis is 3 different kinds: Hep A, Hep B, Hep C. Know what each of them are. Okay, we know that Hep A is spread through fecal oral. We know that Hep B is bloodborne. Okay, we know that Hep C is bloodborne. Okay, but Hep C is a bit more serious than Hep B. Right, 80%, it's estimated that 85% of people diagnosed with Hep C are going to develop a chronic lifelong infection that potentially leads to liver damage, cirrhosis, liver failure, liver cancer. Hep B does have an immunization. Okay. We've already talked about HIV. This was actually my notes here. What was the rationale? Okay, what about TB? We talked about that a little bit. Okay, we know it's a mycobacterial disease spread through airborne droplets, right? 95% of the people who end up with TB, it becomes latent, right? Meaning not active symptoms. Who hasn't had a TB skin test done? We probably all have, right? For new employment, we're always getting TB skin tests, right? And then the N95, filter respirator is worn by anybody entering the room of a patient with primary TB. This was the rationale. Private room is preferred. Patients should leave the room for only essential activities. Okay. And this is still from week 7, bioterrorism and disaster management. Right, so we have 2 kinds of disasters, man-made and natural. What's some examples of natural disasters?
Hurricane,
Hurricane, earthquakes,
Tornado,
droughts, what?
tornado, flood.
Tornadoes. Yep, yep. And then man-made disasters, on the other hand, are events that are human created. Fires, pollution, water supply contamination. Okay. If you're working in community nursing and in the area of disaster prevention, one of the things you may be working with families and teaching families is how to prepare your kid for a disaster. What do we need? I have this highlighted in yellow for a reason. You need to know this. Okay. So the teaching points for us as nurses working with families to prepare for a disaster: we're stocking enough food for 3 days. We're reviewing the kit every 6 months for expired items. We need to make sure that all family members know where the kid is located. And that family members also need to know how to turn off their utilities in the house. Those are the 4 teaching points when we're working with families to prepare for a disaster. The other thing that's common in all of our towns and cities is mass casualty exercises. Those are conducted annually, usually annually, and they determine who needs to be involved, how is the coordination, how is the response, okay? How much time does it take emergency responders to respond? or for the command center to be activated. I don't know if anybody's ever participated in mass casualty exercises. They're pretty intense. They bring everybody together. They assume that a natural disaster has happened. And everybody who would be involved in that response participates in the mass casualty exercises. Okay? We talked about water being safe, when water can be safe. We talked about exposures to exposure to toxic chemical. This was one of your quiz questions, this paragraph here. And there's a couple of agents that I want you to be aware of with regards to bioterrorism. Anthrax, smallpox, and on the next page, it's sarin. And again, think clinical. If you were taking care of a client that was potentially exposed to anthrax, this is the first box on your HESI prep. If you were taking care of a client who was exposed to smallpox, if you were taking care of a client that was potentially exposed to sarin, what would you see? What would you look for? Well, we know that anthrax affects the skin, affects your GI, and affects your respiratory. Okay, we've talked about smallpox, the rash with red spots that turn into deep pustules and leave craters. Okay, and sarin, severe respiratory issues. That's the key with sarin gas exposure. Anticipates severe respiratory distress. So know each of those three agents and what systems they would be affected and how would they present. The other thing that we talk about during disasters is foodborne illness, food safety. Okay, washing hands, separating raw and cooked food, using separate equipment and, pardon me, utensils. Thawing frozen food in the refrigerator, not on the countertop. Cooking food thoroughly. Not using food beyond its expiration date. These are all our teaching points. Through disasters, we also have waterborne illness issues. We always hear of cholera, giardia, right? That's water that was a cause from water contamination. The other thing that may happen is vector-borne illnesses. Lyme disease, Zika virus, Rocky Mountain spotted fever, malaria. Those are all potentially issues with a disaster. Okay. Questions about any of the week 7 content? Is that a good overview for you?
Yes, I thought so.
Okay,
I liked your blueprint. That's pretty cool.
thank you. Actually, what you're looking at is my lecture notes, but there was so much material to cover. I wanted to bring it up so you could see it. Okay. All right. Week 8, home care, community resources, case management. 4th is care of complex chronic illnesses in the community. I'm not going to review this because this is part of your med surge. All right. So you should already have an idea of what cirrhosis is, COPD, type 2 diabetes, peripheral artery disease, PAD, CVI, chronic venous insufficiency, hypertension. Okay. And at all your readings from week 8, most of them come from the Med Surg book. And you have a little section of pages to read about each one. Okay. And a lot of these complex chronic illnesses are covered on HESI. That's why you see these on your HESI prep. Right? So remember, when you're doing your HESI prep, you may need to go back to your Med Surg book reading from this week. Right? Because remember, your HESI prep is how a patient presents with cirrhosis, I don't really want to know what cirrhosis is. You should know that. What might they present with? How is it treated? Right? COPD. We all know what COPD is. So think HESI prep with regards to these med-surg, these diagnoses. What may they present with? How is it treated? Okay. So let's start with home care. All right. What's home care? There's two main points about home care. Where it's provided and who it's provided for. So where is it provided?
At the home of
At
the
home?
patient.
Yeah. In the client's environment, right? And the other major the other major information piece about home care is it's individualized care. It's not group care. So it's in the client's home, the client's environment, and it's individualized care. Okay, we used to think of home health only being for homebound patients, right? But now think about all we do in the home, right? With so many people with complex chronic illnesses, right? They don't stay in the hospital for chronic illnesses. They may have an exacerbation of something, but then they go home. So we're caring for these clients with complex chronic illnesses that we just mentioned in the home, right? Think of all the IV therapy we do in the home, the wound care we do in the home. Think of everything that's done in the home that never used to be done in the home. It was always done in the acute care setting, right? So the benefit of home care is that one of the benefits of home care is for the nurse to be able to help the patient move towards self-care, move towards independence in the comfort of their own home. Most patients want to be treated in their own home, right? So you have the opportunity to provide primary services, secondary services, and tertiary services. Tertiary, you're there because they already have something.
And it brings down the rate of MRSA too, like communicable diseases in hospitals. So it's best to keep them at home.
Absolutely. Excellent point, Tamisha. Excellent. Okay. Remember, the assessment in the home is a lot different than the assessment in the hospital room. When you go into their home, you are their guest, right? So establishing rapport, a relationship, trust, you're their guest. You're entering into their own home. Okay, and there's lots of different assessments that need to be completed. Safety assessments, environmental assessments, right? Family dynamics assessments, right? So it is important for you to be spending that time establishing that relationship. You are in their home. Okay, one of the Medicare and Medicaid play an important part in home care. They direct a lot of the services provided, right? And skilled nursing services versus not skilled nursing services. And Medicare will only cover skilled nursing services, which is IV therapy, wound care, a skilled nursing service. They will not cover the non-skilled, that's support with ADLs. Okay. Here's where interdisciplinary communication comes in, especially with Medicare and charting, right? Whatever the plan of care is, has to be approved by all the disciplines involved. PT, OT, primary care, rehabilitation services, transportation services, whatever resources they need, medical equipment. Okay, that all has to be approved by Medicare if that's what the patient's insurance is. And if it's a private insurance, it's the same concept. Okay, it's one big healthcare team working for the moving the patient towards independence in their home setting. Okay? Community resources. If you are a nurse working in the community, you need to be versed on what resources are in your community. Because any client you go and visit is going to require some sort of resource, and probably a different resource than your last client. Right? And so one of the things that I had as a school nurse, I had a big binder of resources in the community. Were they domestic violence shelters? Were they food banks, clothing banks, school supplies, Meals on Wheels, maybe Red Cross, maybe crisis pregnancy centers? You got to be aware of what resources are available to all of your constituents in your community. What do you do with the non-English speaking members of your community that need resources? Well, if you don't have an interpreter, you've got to enlist community leaders. Let's say you have a large Vietnamese population, but you don't speak Vietnamese. How do you get information to that group about health fairs, about blood pressure screenings, about free immunizations for the kids, about local shelters, local food banks? You have to seek out whoever works with that community. Is it a spiritual leader, religious leader? Is it a member of the community, a trusted member of the community that works with this particular population? You need to get with them, right? Community nursing is a team effort. You have to seek out the people in the community that can help you. Make sense? Okay, the last topic I want to cover is case management. What does a we hear case management all the time. What does a case manager do? What's their primary role?
Coordinator.
Exactly. Exactly. A case manager is a coordinator of care. Everybody has case managers now. Insurance companies have case management or case managers to manage their high cost clients. Hospitals have case managers. Primary care groups have case managers. Surgical practices have case managers. Everybody has case managers. They're very cost effective because they're coordinating care. Not everybody has to be case managed. It'd be nice if they could, but case management is usually reserved for the much more complex clients that need lots of resources, lots of support, right? High cost, chronic illness clients. Okay, it's definitely labor intensive. You know, case manager for I'll just give you a personal example. I have a little grandson, Patrick, who's 2.5 years old. Unfortunately, he had a perinatal stroke when he was born. All right, so he now has Medicare, but he also has Cigna. Okay, Medicare has just recently come into play. So they have a case manager. My son and daughter-in-law have a case manager from Cigna and from Medicare. Those two case managers are now working together to make sure services aren't overlapped, communication is not missed, because they're both covering costs for Patrick. That's what both of these ladies' jobs are. Okay? Coordinate services. Make sure nothing's missing, make sure nothing's overlapping. Okay? Case management is costly because it's very labor intensive, time consuming, but in the end, it's very cost effective. Okay? I just want to lastly finish up with communication. Okay, case managers require varied types of communication because they're doing so many different jobs. In some instances, and I've highlighted the 4 words I want you to be able to identify. Collaboration, right? So these 2 case managers for my grandson are collaborating, right? They're working with each other towards solutions that satisfy both of the insurance companies, Cigna and Medicare, right? Assertiveness is another type of communication that case managers need to use. It's their ability to present one's own needs. Here's an example. Let's say you have a client that's been diagnosed with a rare type of cancer and needs a certain drug. Unfortunately, the insurance company doesn't cover that drug. So a good example of what a case manager might do is go to the insurance company and try and lobby why their clients should be able to get this drug. Okay, so if my client doesn't get this drug, the chances of chronic hospitalizations are going to be way more expensive than the drug. So trying to encourage that insurance company to provide that drug, even though it's not covered. Does that make sense? You're trying to be assertive and getting something done. Cooperation. All right. When you're communicating with many different players, maybe insurance companies, work, employers, working with the occupational health nurse to try and get people back to work. Everybody has to cooperate. All right. Understanding the occupational nurse needs to understand what the case manager is trying to accomplish and vice versa. Right. And then you have compromising, where you try and find a mutually acceptable solution that satisfies both parties. You may not get all of what you need, but it's mutually acceptable based on the goals of both parties. So those are 4 different ways of communication that the case manager may have to experience as she's advocating for her client or clients. Because that's what a case manager does, advocacy, right? She's making sure, he or she's making sure that a patient has just had open heart surgery, okay, and has spent a week in the ICU, 2 weeks on the floor, and is now going home. Do they have family at home to support them that can help drive them to cardiac rehab appointments, to be there when PT comes, be there when OT comes? That's what a case manager needs to sort out. What kind of resources does this client need? Does that make sense? Case management is a really important part of nursing, whether it's acute care, whether it's rehab, whether it's community. Case managers are in all areas of nursing. Does anybody work with case managers before?
Yes.
And is that their
And
role?
yes, it is. When I work with hospice, so they all have a case manager, and they're like the head point of deciding, what they get: music therapy, massage therapy, all that, and they coordinate the team.
Yeah, that's what a case manager is, the coordinator of care. So if you haven't been exposed to case managers or case management, you will be. As you move out into the nursing field, you will be. Everybody has a case. Organizations have case managers everywhere. It's too bad that all clients can't have a case manager because it's so effective. So it is reserved for the high needs, high cost, maybe multiple comorbidities, maybe a mental illness, substance abuse, several chronic diagnoses. Okay. And then the last part was care of chronic illnesses, but you're going to do that on your own because you've already gone through all the reading and med surg. Okay. And so the chronic complex illnesses are exactly the piece of med surg I was talking to you about early in the term. Right? That this class also has a med surg focus. Even though you may see these diagnoses inpatient, you're also going to be caring for clients with these same diagnoses in the home. And that's why they're on your HESI prep, which means you're getting asked about clients with chronic illnesses on your HESI. Okay? So that's the connection to med surg. Well, if you think about it, patients from acute care go home. Some won't need follow-up care, some will. Your chronic disease, complex chronic disease clients will need follow-up care. What they need in the home will be different from what they need in the acute care setting, but you'll have to have an understanding of the actual chronic illness, right? What to look for when you do your home visit. What are red flags? What are signs that the patient's doing well? Does that make sense? So we covered a lot today, 2 weeks worth. There's a lot you can fill out on your HESI prep. In fact, we only have 1 week left no, we have 7, 8, 9. We have 2 weeks left. Are we in week 8? Yeah, we just have a couple of weeks left of content. Okay? So you can be filling out most of your HESI prep at this point. Okay? Does anybody have any questions about all the content we covered? Do you have a better understanding of the different concepts?
Yes, but I do have a question in regards to, you never sent out the HESI thing, which is perfectly fine, but I have a question. You just basically want a rundown of what we understand from each of those topics, correct?
Correct. And
Okay.
the student who emailed me about sending out the HESI prep, I emailed her back. You know, I wasn't comfortable sharing somebody else's work without their permission.
Okay,
And
no worries. That's
yeah.
fine.
So again, when you think about the HESI prep, think clinical judgment. If you were going to be caring for somebody who was potentially exposed to anthrax, think about your nursing process. What might they present with? Is there a treatment? How is it transmitted? Think clinical. You are taking care of them in a clinical setting.
So you want the HESI prep as like, what are the signs and symptoms and the treatment, correct?
How would you take care of a client
Right.
that had a below the knee assessment, below the
Okay.
knee amputation?
Gotcha.
What would you be looking for a client that has tube feedings? I think that's on there. There's a lot of med surg on there, especially in the home care setting, right? And all the questions in the health education, the boxes in the health education section. What would you want to teach? How would you want to teach it? What would you want the client to know? Again, you're in the setting with the client. Does that make sense? What I want you, the ultimate goal is for you to have an understanding of what each of those boxes represent, because there's a question on the HESI about each and every one of those boxes. So what do you want to know? What would be helpful for you to know about that topic? And come up with questions in your mind. What might they be asking about elder health diet? Well, I'm thinking, I don't know what the questions are. It comes from a bank, like your NCLEXs, or like your board questions, but an elder healthy diet. I would want to be knowing, what does that look like? Encourage this, encourage that, stay away from this. Does that make sense? As you're looking at each of these boxes, think, what kind of question might they ask about preschool screening? Well, why do we do preschool screening, vision and hearing screening? Well, do that because we try and identify any issues early on, right? Any hearing issues, any vision issues early on, so we can get those corrected as they enter school, right? Does that make sense? There's no
Yeah.
right or wrong way to do this. This is giving you a heads up of what you're going to get asked about, what topics you're going to get asked about. So what do you want to know about each topic?
I have a question, Professor. Are we gonna have a HESI review in that case?
Yeah. That was asked yesterday in Monday's class. In the master review schedule that I sent out in week 1, it includes exam 1 reviews, 2 reviews, 3 reviews, and the last line is the HESI review. So there's 3 different HESI reviews in week 10. And that's in addition to class. Okay.
Okay, thank you.
Because in week 10 you have an exam. So we covered week 7 and 8 today. Next week we'll cover week 9, and that's it. So whatever the concepts are for next week, that's it. Right? Because week 10 is an exam, and then you jump right into HESI. So week 10, during your exam week, there are also HESI reviews. So Barbara, that's on that master schedule. Okay?
Thank you.
Anybody have any questions? I hope you guys have a good rest of the week. Reach out if you need anything. Okay? It was good to see everybody.
Thank you, Professor.
You're welcome. Barbara, I'm gonna log off and log right back on. All right, so we need to log off because this is the class meeting, and then I'm gonna do another Zoom here in a minute after I answer any student questions. So come back on in a few minutes.
Okay, thank you.
All right, yep. Tamisha, do you have a question? Iris, Fidel? No? Okay.
No, ma'am. Have a good weekend.
Hey, thanks for all your participation. I appreciate it.
You're welcome. You have a great day.
All right, you too, Tamisha. Iris, do you have a question? Iris, are you there?